I would like to welcome all of you for this wonderful webinar talking about the optimal selection of RAS blockers, especially in the post-MI setting. So we have a wonderful panel here waiting for you today, and thank you so much for joining in this busy Friday evening. So we have the moderator of Dr. C.K. Ponde. Sir is a DM cardiology at Hinduja Hospital, Mumbai. Sir, of course, doesn't need any introduction altogether. Sir has been a part of various clinical trials and has multiple publications under his end. So we welcome here Dr. C.K. Ponde as a moderator today. Apart from that, we also have Dr. Mainak and Dr. Kiran, who are going to be an expert panel from Kolkata and Mumbai all together. So we welcome here Dr. Mainak and Dr. Kiran as well. With this, I would like to hand over to Dr. C.K. Ponde for his talk on optimal selection of RAS blockers, especially in the post-MI settings. Sir, over to you. You can share the screen from your end.
Okay, thank you, Ronak.
Yes, sir, your screen is visible. Yes, it's on full screen.
Yeah.
Please go ahead.
So today we are going to talk on the or discuss rather on the optimal selection of RAS inhibitors in the post-MI patients. The renin-angiotensin-aldosterone system, as we know, is a absolutely fundamental neurohormonal axis in heart failure, coronary artery disease, and hypertension. We know that blocking the renin-angiotensin-aldosterone system has worked very well to improve mortality and reduce morbidity in patients with heart failure with reduced ejection fraction. It has also worked excellently in garden variety of hypertension and in resistant hypertension as well. And also the ACE inhibitors in particular, which uh, are the pioneer molecules in the RAS blockade, have shown significant benefit in terms of reduction of MACE and even cardiovascular mortality in patients with coronary and stroke risk factors such as diabetes, hypertension, and even metabolic syndrome. And this was shown in the HOPE trial to begin with, and later on in multiple trials, like PROPHES and so on. But post myocardial infarction patients form a very select subgroup of patients in clinical practice where RAS inhibition is important, but there are sort of dichomatous evidences in which RAS blocker is ideal to choose in the post-MI setting, particularly within first 1 year of acute myocardial infarction. So let us begin with this that we have angiotensin receptor blockers, we have ACE inhibitors, and now we have ARNI as well. And then what the current guidelines say. We'll quickly review this. Let us start with the ARBs. So Optimal and Valiant were two studies done back to back. Optimal was losartan versus captopril in patients with acute coronary syndrome, and Valiant was valsartan versus captopril or valsartan and captopril together versus placebo in patients with uh, acute myocardial infarction. So Optimal 2002 trial, we all know that this was the a very, very coveted trial at that time by Dixon. And this enrolled a handful of patients with acute myocardial infarction, and losartan was compared head-on against captopril. There was non-significant difference in total mortality in favor of captopril. And the conclusion of the trial was ACE inhibitors should remain the first choice of treatment in patients with complicated myocardial infarction. losartan cannot be generally recommended as a first alternative for this kind of population. In Valiant, where valsartan in acute myocardial infarction was used, the rate of the secondary endpoint of death, cardiovascular causes, and recurrent MI was similar in the groups of valsartan, captopril, or valsartan plus captopril. But when valsartan was used with captopril, the incidence of hyperkalemia was prohibitively large, so that that particular arm was to be condemned in future um, propositions. Then we had this brilliant trial of comparing angiotensin receptor neprilysin inhibition ARNI uh, following acute myocardial infarction versus ramipril. And this was, I remember, Pfeffer et al.'s trial, a great trial indeed, where um, acute myocardial infarction patients within 5 to 7 days with LVF less than 40% and or all pulmonary congestion were, were randomized for ARNI versus ramipril. And apart from acute MI and LVF less than 40 and or all pulmonary congestion, they needed plus any of these risk enhancers such as elderly age of more than 70, EGFR less than 60, diabetes, prior MI, atrial fibrillation, Phillips class 3 or more, and STEMI without reperfusion. There was no running period absolutely, and it was an event-driven trial. The dose was sacubitril valsartan 100 milligram BID versus ramipril 5 milligram BID. And if you can see this primary outcome, composite outcome of cardiovascular death, first hospitalization, outpatients, heart failure, sacubitril valsartan numerically lesser composite endpoint, but the p-value was not statistically significant. Same way, primary outcome not statistically significant, cardiovascular death not statistically significantly different, heart failure hospitalization is also not statistically significantly different, and so also outpatient heart failure. But numerically, there was a trend towards um, uh, RD. However, hypotension was far more frequent with ANI, and the cough was far more frequent with lamivudine. And therefore, sacubitril valsartan did not result in a significantly or low rate of CV death, HFH, heart failure hospitalizations, or outpatient heart failure requiring treatment. But the pre-specified observations of reductions in both investigator-reported primary composite and total adjudicated events were little bit in favor of sacubitril valsartan. And then all these write-ups occurred in Medscape, ACC, uh, and many other uh, documents saying that sacubitril valsartan can't beat ramipril in patients with acute MI. ARNI does not surpass ACE inhibitor after acute MI. Paradise MI makes me question the benefits of sacubitril valsartan, etc., etc. And Paradise MI did not outperform ACE inhibitors after acute MI. I agree with all that. At the same time, I must say that once that acute phase is over, then we are left with a bunch of patients at our hands where there is significant amount of left ventricular dysfunction at our hands um, uh, with a primary angioplasty performed or not. And these patients then need further treatment to prevent ventricular adverse remodeling and also incident heart failure. So in this group of patients, we in the first year, which drug to use? So currently, the evidence all is strongly in favor of ACE inhibitors, particularly ramipril. So let us go to ACE inhibitors now. And there are several post-MI trials for the ACE inhibitors. We all know them. They are quite old trials. SAVE trial, where ejection fraction less than 40% were enrolled. AIRE, here the patients were in clinical heart failure during acute phase. And TRACE, with trandalopril, where the wall motion score was significantly low. That means there was extensive wall motion abnormalities with EF of less than 35. And then there were broad ties like consensus 2, GC3, and ISIS 4. And I will just quickly have an overview of these trials for the sake of our discussion. Same 1992 trial, very, very old trial, almost 34, 33 years old. Survival and Ventricular Enlargement Study, SAVE. Randomized double-blind placebo-controlled trial with this setting of the patients was myocardial infarction with LVF less than 40, randomized between 3 to 16 days. And the MUGA, multiple uptake gated acquisition. That means MUGA calculated LVEF was done at baseline and at 36 months, 3 years. And captopril, maximum 50 milligram TDS versus placebo. And captopril group showed significant reduction in mortality and 25% reduction in recurrent myocardial infarction. It showed that the captopril reverses ventricular remodeling, and these benefits occurred equally in patients who received lysis and beta blockers or not. So, irrespective of use of beta blockers and or lysis, captopril did show the benefit. Then trandolopril in patients with MI again. So AMI with wall motion index of less than zero point 0.2, again randomized between 3 to 7 days. Trandolopril 1 milligram per day versus placebo. Again, 25% reduction in mortality and 15% reduction in the recurrent MI, and also significant 20% reduction in sudden cardiac death at around 24 months of follow-up. And then there are other evidences. As I told you, ISIS-4, captopril was effective in reducing 5-week mortality, and the survival advantages appeared to be maintained over the long term. GC3 1994 trial, lisinopril started within 24 hours of MI, effectively reduced mortality and ventricular dysfunction. And CCS1, anterior wall infarction patients uh, are better off with captopril versus no captopril. And then came the AIRE. AIRE trial was randomized double-blind placebo-controlled multicenter trial with acute MI patients with transient or persistent heart failure, randomized between 3 to 10 days with oral ramipril versus placebo, followed for 15 months. Short trial. Ramipril group showed 27% reduction in mortality, 19% reduction in the rate of recurrent myocardial infarction and stroke at as early as 6 months. So the curves have started diverging in a significant manner as early as 6 months, and the benefits were maintained till the end of the study, which was around 15 to 18 months. But what was more important, and this is extremely impressive and extremely important to remember, that AIRE extension study was then published in 1997. What was an extension study? The 603 patients who participated in the AIRE study were followed up much longer, for 42 months to 60 months. And the beneficial effects of ramipril started early after MI and were sustained to 3 to 4 years. Despite that is a brilliant finding, despite discontinuation of medication at 1 year. So at one and a half year, the primary trial ended, right? And the trial population patients must have discontinued ramipril. Yet the reduction in mortality and benefits persisted up to 5 years. So treatment of 9 patients with ramipril for an average of 1 year will result in one additional survivor or one life saved in 5 years. So that is a very, very uh, great thing that ramipril did. And then the ramipril's long-term survival benefit in acute MI patients was AIRE survival study, was published in 2021. And again, those 603 patients uh, with a duration of approximately 30 years were studied. And can you ever imagine that median survival time was 8.3 years in the placebo group versus 9.6 years in the ramipril group. Life expectancy was greatest at about 15 years. And extension of life to those patients who were involved in the trial who probably did not take captopril after the trial was over was still almost 1.25 of years, that is around 15 months. So every single patient who can take ramipril for a period of even 1 year after an acute MI gets extension of life of approximately 1.5 year uh, over 30-year follow-up. And that is extremely impressive. And these results persisted whether the patient had diabetes or no diabetes, etc. And look at this. In diabetes, life expectancy difference. Previous MI, previous heart failure, hypertension, angina, and elderly age. All this, the benefit was much, much higher with Ramipil compared to the placebo. So in diabetes, 32 versus 5, previous MI 20 versus 5, heart history of previous history of heart failure 20 versus 5, hypertension 17 versus 8, angina 16 versus 5, and elderly age 11.3 versus 7 versus 6. So for every day a patient received Ramipil in the first year of MI, his life was extended by another day, further one more day. So one day of Ramipil, one day extension of life, and that's a great thing any drug can do in a patient with acute MI. And relative risk of survival in patients with diabetes was increased by 54% in this trial. So this is the what we call AIRE survival study. And therefore, treatment of Ramipil for about 1 year, when started early in post-MI patients, results in a survival benefit which is sustained for many, many years, up to 30 years, and offers on an average one additional year in the patient's life. So, what do the current guidelines say? If you look at the post-MI state-of-the-art review of the JAC by Bahit in 2018, you can see here early initiation of ACE inhibitor within the first 24 hours is strongly recommended. 40% of survival benefit for ACE inhibitor is conferred in the first day. First day. So, my friends, don't hesitate, don't have prejudices, don't have apprehensions. If the pressure is fine, if the potassium is fine, if the EGFR is above 30, please start a ACE inhibitor in the first very day after myocardial infarction because that itself gives 40% survival benefit. So it is very, very important to do that. And this write-up also says it is important to titrate medications uh, up, up and up and up so that you can get maximum benefit. The Jack acknowledged AIR study, the first Ramipur study in 1993 of Lancet, and has given class 1A recommendation for starting ACE inhibitors in the first 24 hours of acute MI with heart failure, clinical heart failure, or with ejection fraction less than 40. And we have 3 trials to support that: SAVE, AIRE, and the TRACE trial. So 2020 ESC guidelines gives class 1A recommendation to ACE inhibitors uh, in patients with acute heart failure and reduced EF um, with diabetes or CKD unless contraindicated in order to reduce all cause and cardiovascular mortality and morbidity. So this is in patients with non-ST elevation ACS. And even the ACC-AHA guideline gives same class 1A recommendation, high-risk patients with ACS who have EF less than 40, hypertension, diabetes, or STEMI with anterior location. So please remember that this is the evidence I just wanted to put in front of you in a very crisp manner so that our discussion becomes fruitful. So, Dr. Ravanath, can we start the discussions now, or you want to chip in for a while?
No, sir, we can begin the discussion.
All right. So, my my colleague experts are here with me, Dr. Maina and Dr. Sorry, I
Dr.
can't
Kiran.
see them. No, I can't see them.
Dr. Mainak and Dr. Kiran, requesting you to please
Am I audible?
switch on your cabin. Yeah, yeah, you're audible, sir.
But I just can't see. That's the thing.
Sir, could you please switch on your camera as well?
Yeah. And who else is there? Dr. Karan, no?
Dr. Kiran.
Kiran. Is he there?
So Dr. Kiran is joining. He dropped out due to network issue. He's just
All right, all right.
joining one
So
second.
let me start this discussion with Dr. Mainak.
Yes, sir.
And in the post-MI patients, post-revascularization, whatever, I mean, if you have done a PAMI or you have done a thrombolysis, patient has settled down, at at what systolic BP are you comfortable to start an ACE inhibitor?
Sir, any after PCI, the one very important thing is that I would not like my patient to have hypotension. So that
Exactly.
a very important thing.
Yes.
So if the systolic blood pressure is something more than 100, then definitely I will start with Ramipril at a very low dose, because it's even after the revascularization, it is quite important to start at least one ACE inhibitor, and I will keep an eye on the blood pressure. If it
Yeah.
scores something below 19, then definitely I will hold it for some days, or I will adjust some other molecules which are having some uh, contraindications because of low BP. But otherwise, I
So
will
let us say
definitely start at least.
what starting dose of Ramipril do you normally use? 1.25 or
Usually, I
2.5 or so?
start 1.25 twice daily if the patients there is LV systolic dysfunction,
Yes.
and then gradually I will up titrate accordingly,
Yes.
and I will always try to reach this 5 milligram twice a day, at least
Yeah.
within first 2 to 3 weeks, or if not more, at least within for the first 4 weeks, if possible.
Yeah. I think that's very reasonable, Dr. Mainak. I'm sure all of us are doing the same thing. We are afraid, we are little apprehensive about hypertension because hypertension is, there are three problems with hypertension. If the audience wants to know, and that one problem is with hypertension, if you have ischemia at a distance, suppose the LED is blocked, in Dr. Mainak has opened the LED, but let us say rightfully there's another lesion in circumflex which he has left alone to be tackled little later. Hypotension will increase ischemia at a distance. It might make the other zone ischemic because of the poor perfusion. That is one problem. Second problem of hypertension is patient may need inotropes and his ICU stay will get prolonged, right? And the third and the biggest problem is hypotension may produce pre-renal azotemia and worsen the renal function. So these are the three problems which are produced by hypertension. Therefore, nobody wants hypertension. So as Dr. Mainak said, very, very correct. Thank you, Dr. Mainak, for that great insight that unless the blood pressure is at least 100 systolic, we don't start ACE and we start at a very small dose so that the patient's body and the hemodynamics gets adjusted to that dose, and then slowly over the next 4 weeks titrate to the 5 milligram BID dose. And that's absolutely correct thing to do. Now, unless the Dr. Kiran has joined, I don't know. Will you switch the patient to an ACE inhibitor? This is very common problem. Let us say a hypertensive patient who's on telmisartan 40 OD lands up in acute anterior MI, right? Now, post MI, his pressures are good. Like you have done a PAMI, and the pressures are good, 130, 140. Now, will you switch from telmisartan to an ACE inhibitor or no? And
Yes,
that's a
sir. I will
million-dollar
switch.
question.
I will switch.
You will switch. And
Yeah,
that
I
is
will
because,
switch,
and why would you switch? That is the
because
question.
we have got the highest number of data with the ACE inhibitor than the ARBs for this particular group of patient.
That's
And
right.
another thing is that the two trials which has been tried with the ARBs, like the Valiant or Optimal, they are those are the non-inferiority trial. There's no superiority data,
Yes.
and the N value is also relatively less with respect to the other trials with the ACE inhibitors. And we right at now we are having a very long-term data of the AR trial with Ramipril, which is something around 30 years, which is not a really a matter of joke. 30 years data, we must go by that data. So that is the reason I will always try to convert the ARBs to ACE inhibitors at least up to the AMI.
So right now we don't have captopril available at all. Lisinopril is also available, but very not very freely. So I think our molecule of choice at the current time remains Ramipril, which is very freely available and very original molecules are also available from the original manufacturer. And also, of course, we have great trust in this molecule because we have used it for other indications also with great degree of efficacy and safety. So I think you are right that the data is very strong with ACE inhibitors, and we will shift to ACE inhibitors if the patient is already taking Ramipril. Oh, sorry, already taking ARP. Now, post revascularization, let us say if you find the LVF is 35 or 38 or whatever, less than 40. But there is no clinical heart failure. This patient does not have pulmonary congestion, does not have resting tachycardia. He's not having a poor urine output. He's what we call ACC AHA stage 2 heart failure. That means structural heart disease like MI, LV dysfunction like heart failure patients have, but no clinical signs or symptoms of heart failure. So this is asymptomatic left ventricular dysfunction, which is stage B of ACC-AHA heart failure. So in this patient, will you use AS or will you use RT in the first year after MI?
Absolutely is. Because the first thing is that whether we need therapy for this group of patient, definitely answer is yes, because the symptom is not that important. This patient can definitely have symptoms in the coming days. My aim is at least to retard or to halt the systolic dysfunction or the ventricular dilatation of this group of patients. So naturally, I will have to block the entire angiotensin pathway. And for
Yes.
that reason, definitely I will start with the ACE inhibitor in the day one of this
Yeah,
particular group of patients.
correct. So asymptomatic LV dysfunction, we have got a SAVE trial with captopril to prove that. And then second trial was the TRACE with trandalopril, proving the same thing. If you have EF less than 40, with or without clinical heart failure, doesn't matter. Even without clinical heart failure, these patients tend to benefit in terms of reduction of, number one, cardiovascular mortality, number two, sudden cardiac death, and number three, they reverse or at least prevent adverse ventricular remodeling. That means they prevent ventricular dilatation, they prevent incident heart failure. That means if you leave, let us say, 100 patients like this without treating them with RAS blockers, almost 20 will develop heart failure, clinical heart failure by the end of 6 months. Whereas if you treat them, only 3 or 4 might develop clinical heart failure by the end of 6 months. So the risk reduction in terms of incident heart failure is phenomenal. And we have great data in the literature to prove this point, which Dr. Mainak was saying that ACE inhibitors clearly are the option here and the first therapeutic option, particularly in the setting of early post-MI period. So the next uh, question is little digressing this. It is on the
Dr.
beta.
Pandey,
Yes.
just would like to address that Dr. Kiran is also here with us.
Yeah. Can you tell him to switch on his video, please, so that I can see? Because as some surprising, I'm not able to see anyone in this chat box other than Dr. Mainak. I don't know why is that.
Dr. Kiran, over
Yes,
to
sir.
you.
Yes, yes.
Could you please switch on your camera as well?
Hmm.
Dr. Pandey, please go ahead.
Yeah. Okay. Uh, Dr. Kiran, now this question you can take. When do you like to start a beta blocker in a patient with acute MI? I mean, how early is you are comfortable? How early you think is the benefit occurs when you start a patient on a beta blocker? And which will be, if you once you answer that, the next is which will be your preferred beta blocker? Hello, Dr. Kiran. Is he there or is he disconnected again?
Oh, just a sec. He got disconnected, sir.
Oh my God. Oh, okay, okay. So
May
no
I just,
problem.
may I can take the question, Dr. Pandey, because I think
Please,
he is
why not?
disconnected again.
Yes.
Yes, sure. So the thing is that at the very early stage of the post AMI, whether we have revascularized or not, again, the initial 1 or 2 days is a very sensitive phase for the beta blocker use. Particularly even if the patient is having some hypotension or lower pulse rate in inferior AMI with CHPs and others. But so it is always better, what I personally follow, to use the short acting beta blocker for the first initial few days.
Yes.
So in that case, the metoprolol tartarate is the salt that I use. because the duration of the action is shorter, I will be able to use it in multiple divided doses. Then maybe after the first 48 or 72 hours, I will switch over to the subsequent long-acting beta blockers, provided the patient's heart rate and the BPs and all other things are fine, and the failure is also well controlled. And yes, we have got a multiple choice of beta blockers over here, but most of the times we are using the long-acting salt, the metoprolol succinate. But again, we can use the carvedilol also. But the carvedilol or the bisoprolol will the more potent, so the BP reduction chance is quite higher unless the patient's blood pressure is in a safer zone. So mostly we are using the metoprolol succinate salt, and the initial starting dose I will use at a 12.5 milligram once a day when I'm using the long-acting salt, and gradually I will up titrate it to reach a heart rate resting something around 50 to 6 or something around 60. But and how I am going to uptitrate it completely depends upon the pulse rate reduction and the patient's hemodynamics. But maybe just after initiation, I will just uptitrate after 7 days, and gradually I will try to reach the maximum possible tolerated dose. And
Yeah.
regarding the use of ACE inhibitor plus beta blocker, definitely it is a very common combination that we are using in the LV dysfunction patients, in particular this group of patients. But again, we'll have to keep an eye on the blood pressure and the pulse rate also.
Sure, sure. Yeah. So, so most of your patients post MI should go home, or most patients should go home at least on a small dose of ACE inhibitor and a small dose of beta blocker, because these are the two drugs which reduce 90 days and 1 year mortality. They improve survival. They reduce sudden cardiac death. They prevent incident heart failure. They prevent also adverse ventricular remodeling like ventricular dilatation, etc. So these are the really, really important neurohormonal blockade combination that we have, which we can use in post-MI period. But unfortunately, Dr. Mainak and Dr. Kiran, unfortunately, let me tell you
Mm.
that in 2018, 2006, no, not 2018, 2017, we have 5 cardiologists in my institute, and we have got 4 physicians and 3 intensivists. And so many of them, they treat their MI patients themselves once the intervention is done. And yet we found that not even our quarter patients used to go home on both these drugs for some strange reason. And the 3 biggest reasons were: number one, apprehension about hypotension, apprehension about renal dysfunction, and apprehension about hyperkalemia. So what we did was we employed 2 physician assistants in my department, and they kept on pointing us the mistakes of omission. And finally, now we have reached a stage where almost 3 quarters of our patients do go home on both these drugs at the time of discharge, albeit whatever in small doses, but they do go home on both of these disease modifying drugs. So now let me involve Dr. Kiran in the discussion. Do you consider NT-proBNP as a deciding marker for choosing choosing ARNI over ramipril in post-MI patients? Do you think that uh,
No, no, sir.
correct?
No, sir. Anti-proBNP is prognostic and a diagnostic marker for cardiac failure.
Yes.
So we do serial monitoring of anti-proBNP to check for the response. And
Yes.
we see once the drop in the anti-proBNP of more than 25% or up to the baseline, then we consider to be a good prognostic factor and for discharge. And it is not a
Yes.
mark like a deciding factor to choose ARNI over ramipril as such.
Okay. Great. Great. So no, why this question came, I will tell you that if you look at the Paradise MI, the decrement in the NT-proBNP was with ARNI was quite substantial as compared to ramipril. The subgroup analysis I mentioned, the appendix says that. The other thing is that in certain trials like Victoria with vericiguat, people with the highest quartiles of NT-proBNP did not benefit with vericiguat. So people with very advanced heart failure, they really don't benefit with Verisugot. So keeping that in mind, uh, uh, does this marker make you decide? And I really appreciate your question answer. It's a very thoughtful answer that you have given, and that's a correct answer also. That NT-proBNP cannot decide whether you choose ARNI over Ramipral. In the first year after MI, the evidence is very strongly supporting ACE inhibitors over ARNI. And we also have a problem if you are worried about hypotension. Then even in the paradigms, the incidence of hypotension was far more frequent with ARNI as compared to Ramipral. Then the next question, Dr. Kiran, to you is: will you start an ACE inhibitor in all patients with ACS, whether revascularization was performed or not, to get the mortality benefits? What is your take on that?
Yes, sir.
Whether done a
Yes,
PAMI
yes,
or
sir.
no
In
PAMI,
all
lysis or no
ACS.
lysis.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. In all the patients, we start with AC inhibitors, irrespective if patient is revascularized or not, because this it is it decreases the mortality, and it primarily works at the level of myocytes, and it remodels the myocardium. So it will give a mortality benefit to the patients who have or haven't undergone revascularization. So it is rather
Correct.
the first drug. Sometimes once after a patient gets gets an acute coronary syndrome, and we are not able to start beta blocker in any form, then we usually start with AC inhibitors as compared, like we start with an AC inhibitor first rather than going for
Correct.
a beta blocker first if patient is not able to tolerate due to any other, or is contraindicated due to any other reason.
Correct. Correct.
So we
So
have to start with AC inhibitor irrespective of
revascularization not. In fact,
revascularization.
AIRE
Yes.
trials showed the same thing, that the risk reduction with Ramipral compared to the placebo was there, irrespective of the patients whether they were revascularized or not, and irrespective of whether they were on beta blocker or not. So this is very important that patients should be given ACE inhibitors. And the most important part is first 24 to 48 hours you may not give a beta blocker, because the benefit of beta blocker is not seen in first 2 days. But just starting an ACE inhibitor on the first day itself reduces 30-day mortality by a staggering 40%. So it is important that one must uh, start ACE inhibitors as early as possible. Now, what percentage of your patients tolerate ARNI? I think this is a typographical error. 100 milligram BD versus Ramipral 5 milligram BD, which was given in Paradise MI trial. So, how many patients with MI may tolerate this dose, 100 milligram BD? I personally don't think so, because that situation is little labile. Patient may be in heart failure in the first day or two with little bit of Krebs, wet lungs. We have given some loop diuretics with which his intravascular volume is little depleted. Such patients will never tolerate ARNI 100 milligram BID, out of question. So, in fact, our starting dose, even in non-MI heart failure patients, in such patients is 50 milligram half tablet twice a day. And then slowly we build it up, isn't it? So I don't think they will tolerate this versus Ramipral 5 milligram BD. But Ramipral 5 milligram BD also, as Dr. Mainak has said in his talk, very lucidly, and I appreciate that, Dr. Mainak, that you said you'll be starting a dose of 1.25 BD, and slowly by 3 to 4 weeks, you may be able to reach this dose of 5 milligram BD. So start low, go slow, and reach the target dose by 4 weeks. Start low, go slow, and reach the target dose by 4 weeks is the mantra for starting ACE inhibitors and beta blockers in the setting of acute MI. So I think if there are any more comments from both of your side, I would really
Sir,
love to hear them. Please.
sir, sir, like, what do you consider, sir? Starting Ramipil twice a day or once a day first, and then going up twice a day? Because the half life is
No, I know
19 to
Ramipral has
20
a
hours.
long half-life, but there are at least two studies showing that when you start a small dose, the BID pattern works better than the OD pattern. That is very clear. There are at least two studies. And the other thing is that once you reach a dose of, let us say, 10 milligram a day, again to divide that into two doses is quite reasonable, because when you don't land up in a large dose hypotension 3 to 4 hours after that large dose. So splitting 2.5 BD, then making 5 milligram BD is a good thing to do. And most of the previous trials have done that. Even AI, it was like that only. 5 milligram BID was the dose. Even in Paradise MI, the dose was like that only, 5 milligram BID. So any other inputs? Any other inputs
Very,
from you?
very nice discussion from your end. I think that all of us must have been enlightened through your discussion.
Dr. Mainak, we couldn't hear you well.
Yeah, I was just thanking Dr. Pandey sir for the nice discussion, and I'm pretty sure that all of us must, those who have attended this meeting, must have been benefited and enlightened well.
Sir, extremely sorry. Your voice is very muffled. Is it okay if you can talk close to the microphone?
Am I audible now?
A bit better, sir.
Okay. I was just telling that the discussion has been very fruitful, and I think that all those who have attended this today's discussion must have been benefited and enlightened on this particular very important topic by Dr. Pandey.
Right, sir. Dr. Pandey,
Yeah,
we have,
I'll call you.
yeah, so we have all the comments from Dr. Mainak and Dr. Kiran as well. If we can just summarize today's discussion and go
All right. So
forward.
let me summarize. Uh, RAS system, renin angiotensin aldosterone system, is the absolutely fundamental neurohormonal block axis, which, when blocked, gives immense benefits in three spheres of patients with us. Number one, patients with heart failure with reduced ejection fraction. Number two, post-MI patients. Number three, hypertension, garden variety, and resistant. And number four, reduction of MACE and cardiovascular death in patients with multiple cardiovascular risk factors. So, HOPE study and HOPE 3, etc., they showed the same thing. So, we have these molecules with us, ARBs, ACE inhibitors, and ARNI, and they have their separate niche areas in which they succeed, and they give us immense benefits. ARNI has proved better than ACE inhibitors in heart failure with reduced ejection fraction, which is not a post-MI patient, but a post-MI, immediate post-MI patient within first 1 year of acute MI with reduced EF of less than 40, with or without heart failure. It is the ACE inhibitor, which is a better molecule to use, and a humongous data to back that. SAVE, ISIS, GC, TRACE, and so many, and AIRE, and so many trials. So there's no question you have to use an ACE inhibitor. Number two, starting an ACE inhibitor on day one reduces 30-day mortality by 40%. Number two, giving ramipril in the first year of post-MI, every 1 day of ramipril increases the life of the patient by 1 day. And that is so very important. Next point, even if the patient uses ramipril for 1 year and then does not use ramipril at all, yet at the age of 30 years, he gets the extension of life by around 1.5 years. That is called legacy effect. This kind of legacy effect has not been documented even with ARNI, for that matter. This kind of legacy effects is seen only with one beta blocker, that is bisoprolol. It is not seen with metoprolol. It is not seen with carvedilol also. So I think this is a great message for the physicians to take, that start your patients on ACE inhibitor on day one and you will never regret it. You will never regret it. Number four, starting blood pressure should be at least 100 to 110 systolic. As Dr. Mainak said, start a slow dose, build up slowly over the period of next 4 weeks, keeping the careful watch on creatinine and potassium and systolic blood pressure, particularly symptomatic hypotension. Next is that beta blockers are complementary to ACE inhibitors in this scenario, and starting beta blockers on day 3 or day 4 when there is no clinical heart failure, when there is no bundle branch block, and there is no bradyarrhythmia is extremely important to reduce cardiovascular mortality and morbidity by 1 year. Beyond 1 year, unless the ejection fraction is low, there is no benefit of beta blocker. So beyond 1 year, no beta blocker. And the next and the last but not the least is that, and that's the great punchline message is that each pillar of RAS inhibition has their own niche areas. Post MI, it is ACE inhibitor. HEPREF, non-MI, it is RV. And garden variety of hypertension, micro or macro albuminuria in a setting of diabetes or no diabetes. It is the ARB. It is the ARBs which succeed better than ACE inhibitors. MACE reduction and cardiovascular death reduction in patients with multiple cardiovascular risk factors with or without hypertension. It is only ACE inhibitor which does that. ARBs don't do it. In fact, there were several studies showing that ARBs increase the risk of myocardial infarction in patients with cardiovascular risk factors, particularly in patients with chronic coronary syndrome. So these are the messages to be taken from our today's webinar. Thank you very much indeed. And I thank profusely Dr. Kiran and Dr. Mainak to be there with me. They are great physicians and clinicians. And
Thank you,
thank you
sir.
very much.
So thank you so much, Dr. Ponde, Dr. Mainak, and Dr. Kiran for joining us today. And Dr. Ponde, you have summarized the entire discussion very fruitfully. And I'm sure everybody who's here in the audience has gained insights from your clinical practice, and it will help them going ahead in their practice as well. So with this, I think we can end today's call if we don't have any other questions from the chat box.
Thank
So,
you and God bless. Thank you.
yeah, thank you so much, sir. Thank you so much, everyone. Have a good evening.
Thank you.
Thank you.
Thank you so much, Dr. C. Ponde, sir, and Dr. Menak. Thank you. Yeah, I guess. Yeah. Okay. So I think we can end this and we'll connect. Yeah. So Nira, we can go offline.
Recording stopped.
Okay, great. So thanks, Nira, for hosting this program.